from Buffalo, New York. Welcome to Egypt, and we hope to enjoy your lecture.
Thank you very much, and good morning to everyone, and I very much appreciate the opportunity to talk to this group about a brand new direction in treating patients with truly refractory ventricular tachycardia, those that have failed drugs, many times ablation, have defibrillators in place, and yet they continue to have many episodes of ventricular tachycardia. To set the stage for this new approach involving stereotactic radiation therapy, I need to step back in history just for a moment. In the early 1980s, I had the privilege to serve as the inaugural director of the Arrhythmia Group and Electrophysiology Laboratory at Washington University in St. Louis, and also had the opportunity to work with many innovative people, including Dr. Jim Cox, who is a world-famous arrhythmia surgeon. And one of the things we did together was to truly build the first three-dimensional 190 lead interoperative mapping system and actually use it in humans. And we used this mapping system to help Dr. Cox identify what area of the myocardial border zone should be resected. But probably as importantly, we learned more about human ventricular tachycardia and its three-dimensional nature. This is a slide that shows one beat of ventricular tachycardia in the left-hand side, and the heart's been sliced from base to apex with the left ventricle, right ventricle, and the black area denotes the core infarct. And the loop is the three-dimensional intramural reentrant circuit, and there is examples of tissue from each of those areas, and I just want to focus on site D and point out that this is right from the border zone, and it shows what we've known about now for many years, and that is that anatomic electrophysiologic region around the border zone is made up of viable myocytes shown in the dark color, but interspersed with multiple strands of fibrosis, and this allows reentry to occur. These data and those of others from around the world set the stage for, instead of doing surgery, using catheter ablation to destroy critical components of this reentrant circuit. This is a cartoon of a potential reentrant circuit and the common exit point here. And so in some cases, for those who do ablation of ventricular tachycardia, it's an easy day to find that exit site, put in ablative lesions, and the ventricular tachycardia is cured. Unfortunately, in many patients, there can be multiple reentrant circuits, and one can spend the day applying multiple ablation lesions before a success is achieved. Radiofrequency ablation for ventricular tachycardia also has some issues associated with it, including it can be risky for patients, and there is a mortality rate associated with this procedure. As I alluded, it is not always effective and less effective in people with non-ischemic heart disease. And as I also alluded to, it can be very tedious and difficult to perform. I'm proud that my successors at Washington University came up and asked the question, can we ablate in a smarter way? And this activity is led by Dr. Philip Kukulich in the Department of Medicine at Washington University, and Dr. Clifford Robinson, who is in radiation oncology. And this was to look at these kinds of patients and do a three-pronged approach. First, use non-invasive EP mapping, such as body surface mapping, modern-day imaging to identify scar tissue in that border zone, and then use radiation therapy, that used for cancer, and deliver high doses of ionizing radiation to the target, which is the entire scar, while giving low doses to healthy tissue. This is just a short video that shows this. So in 2017, this group published the results of the first 5 patients and showed a remarkable reduction very quickly after the therapy. So the 5 patients are shown here. This was the time of ablation. Prior to ablation, they had many, many episodes of ventricular tachycardia, and shortly after treatment, it was eradicated. 2 years later, they published a series that included 19 patients and found similar results, that overall, the median number of VT episodes was reduced from 119 to just 3. So at this point, a few years ago, the initial observations were that patients with up to 3 years of follow-up treated with a 25 gray single radiation treatment produced no damage to the coronary arteries, no injury to the phrenic nerve, no heart block. There were episodes of pericardial fusion, and nearly all people enjoyed a substantial reduction in VT burden. Since then, several groups from around the country, with 6 of them shown here, as single centers, have been able to collaborate those results and corroborate them. And overall, single center data replicate results of early VT suppression, and still looking to see whether or not this is effectively long-term. Other data that have come from the Washington University group and others, as you'll see at the end of this, involved in an international study, asked the question whether or not you needed to ablate the entire scar, or could you do less than the entire scar. And by looking at the data that have been acquired so far, the data clearly show that if you ablate more than 280 milliliters of volume, you run the risk of reduced survival and actually doing harm. If you do less than 22 milliliters, there seems to be an increased incidence of late recurrences and possibly new ventricular tachycardias that develop. And it seems at the moment that between 50 and 150 milliliters of tissue offers the best balance between benefit and risk. So now they're doing less than the entire scar using a process that I'll explain here in a minute. One of the other things that came about as the world got involved in this is to have a Rosetta Stone, if you will, that clearly and reproducibly identifies different regions of the heart during imaging and during ablation. So the group adopted the American Heart Association's 17-segment heart imaging model as shown here. Together, this led to a direct approach, which is first find the scar, find the exit sites, and then ablate the scar nearest the exit sites. And so to find the scar, they've now been able to use across the world many, many different modern-day imaging techniques to locate the infarct and the dimensions of that scar tissue, and not rely completely on body surface mapping, but simply using the 12-lead ECG or voltage maps obtained during attempts at catheter mapping to find the effective VT exit site. These imaging and electrical data are put on that Rosetta Stone of the American Heart Association's image of the heart, as shown here in these three regions in red. These then are superimposed on anatomic images, and a treatment simulation is developed. And then the patient undergoes the ablation.
Area of your body are going to treat. Okay, that all checks out, so we can go ahead and go on in.
All right, that's all she wrote.
So what's most fascinating is that it works, and then the second question is, how does it work? And it appears, again, based on data acquired so far, that there are two phases to the efficacy of this radiation therapy. The first, quite interestingly, is that it promotes an early increase in conduction velocity through that border zone through cellular reprogramming. And then it also produces, as I would have thought would have been the only way that it would have worked, a delayed effect by increasing modestly the amount of fibrosis. And so in the last minute or two, I want to just focus on this increase in conduction velocity. This is a composite slide that shows the results of those first 5 patients and reinforces how abruptly the ventricular tachycardia stops within weeks of the procedure, way before the normal time for fibrosis to truly develop. Here's 2 histologic slides from a patient who underwent this, and then later they were able to retrieve the heart at the time of heart transplantation, and shows the amount of scar tissue shown in blue in an area of the heart that did not receive any radiation, and at the targeted core region of the exit site. So there is some modest increase in scarring, but nothing compared to, this is an example from another patient and another heart that actually had gone through radiofrequency catheter ablation, and shows the tremendous increase in scar tissue. And in these patients, again, the imaging analysis of the scar showed no increase between pre-treatment and post-treatment in gadolinium enhancement with an MRI scan. So it's clear that fibrosis is not the key to early success. To further prove this, the group developed a mouse model in which mice were treated with the 25 gray dose of radiation, just like the humans, and 6 weeks later, tissue was collected. And in the areas of control animals, there is no fibrosis that would exist because they're supposed to be normal. And in the bottom right panel is a heart that was radiated, and again, shows no, in the acute phase of those first 6 weeks, evidence of fibrosis. Conduction velocity increased in the hearts that had received radiation, as shown here, compared to the control, and is shown here in both the longitudinal and the transverse direction. They further took that mouse model and created a experimental infarction by tying off a coronary artery. Here's the scar, here's normal tissue, here's the border zone. And again, in the group that had just the MI, conduction was slowed during that border zone, but in the group that had an MI and were irradiated, conduction velocity actually increased. And then the final step, which I think is pretty elaborate and elegant translational and clinical research, to identify the pathways and the genes that were differentially expressed in response to radiation therapy. They did bulk RNA sequence analysis and found many genes and pathways were increased, with a lot of these being inflammatory pathways. But the most interesting one was reactivation of Notch signaling. And the Notch signaling pathway is a well-conserved pathway in mammalian hearts that is directly responsible for the heart's conduction system during embryogenesis, and directly impacts the genes that encode proteins that make up the sodium channel. And so in a series of elegant experiments that began with the notion that radiation therapy reprograms Notch signaling in mice, and this simply reiterates the experiments that I showed you, there is increased conduction velocity, there's increased in proteins that are involved with the sodium channel, and increased sodium channel activation. This can be affected with infarcts, as I showed. In another group of elegant experiments, they did loss of function and gain of function to further prove cause and effect. And the final piece of evidence is having, over this course of the patients that have actually gone through this, and they've been able to get a hold of the hearts that underwent radiation therapy, either because of transplantation or going in through other kinds of procedures. They were able to do the same RNA analysis of the human hearts that they did in the mouse hearts, and again found increased evidence of sodium channel activity, no dramatic increase in fibrosis, and actually a shortening in most patients of the QRS duration. And with that, I think I will stop and just simply say that this is now a type of therapy that is being coordinated from St. Louis across the world, with many, many sites involved in a multi-center registry using the same Rosetta Stone, the same overall approach. And I think over time we will continue to learn where this type of new therapy is in the evolution of non-pharmacologic therapies for ventricular tachycardia. Thank you.